All right, thanks everybody for coming this morning. So as Dr. Montero said, we're going to be discussing some perinatal diagnoses this morning of some patients who have come through the MFM clinic and the ultrasound over the last several weeks. Again, my name is Evan Monson. I'm one of the third-year residents here at Augusta University and currently rotating with the MFM department. The topics that we're going to cover this morning, we're going to talk about limb body wall complex. We're going to cover neural tube defects and congenital pulmonary airway malformation. Our first patient is a 16-year-old GYN who presents late to prenatal care at approximately 24 weeks of gestation. Pregnancy has been uncomplicated so far, but initially had tried to keep her pregnancy from her family. She has no medical conditions, no significant surgical history, and has only started taking prenatal vitamins. She was referred to our specialized ultrasound after her screening ultrasound noted possible gastroschisis with possibly some liver protruding from the abdomen, and she was sent for our consultation and detailed ultrasound. Going through our images, there were a few things that we noted on our ultrasound. The first was regarding the spine. So as you can note in the left image on these sagittal views, we can visualize some of the cervical and thoracic spine, but are unable to get a full image of the complete spine all in one plane. And so we had to adjust the orientation of the probe to be able to visualize the lumbar spine in the right image. We noted abdominal contents protruding through the abdominal wall. As you can see on this left image, it's a little difficult in this image to differentiate what is what, but superiorly we have kind of the liver and then some of the intestinal contents. And then in the right image, we have here noted the heart and the bladder, and you do have some amount of bladder exstrophy as the bladder begins to protrude from the lower abdominal wall. Here we have a couple of videos panning through the abdomen and through this abdominal wall defect. So on the left, you can note in kind of at the end of the image, you can note the circumference of the physical abdomen with the abdominal wall defect. Play that again a couple of times to kind of get the effect there. At the beginning, you note intestinal contents, and then at the end, you know the liver as we're panning up through the abdomen. And then on the right, where we can know this bladder exstrophy, and again, we visualize the liver outside of the abdomen. On the left, we also note an increased cardiothoracic ratio, where the fetal heart is taking up a larger portion of the thorax than would be expected in a normal infant. And on the right, we'll note limited pulmonary tissue. You'll see it just superior and to the left in this picture to the heart, compared to what we would expect in a normal ultrasound. So we see the heart beating, and then just up and to the left, we note a small amount of lung tissue. So our differential for this patient includes gastroschisis. As we kind of differentiate these, there are minor differences between some and major differences between some of the other differentials. So the first would include gastroschisis. So this is a full thickness abdominal wall defect, typically on the right, just lateral to the umbilicus. There is a normal cord insertion at the umbilicus. This typically includes bowel herniation, typically without liver and without a membrane covering. This is generally isolated without any other syndromic other malformations. Next on our differential would be an omphalocele. So this is a full thickness abdominal wall defect, typically with an amnion peritoneal membrane covering. This can include the viscera, liver, stomach, spleen, and this is generally associated or commonly associated with other anomalies. Included in our differential would be limb-body wall complex, which can have variable presentation depending on the severity of the abnormality. Generally, there's an abdominal wall defect with other thoraco-abdominal or limb defects, as suggested by the name. Typically, this also presents with severe kyphosis or spinal malformations, and there's typically a combination of scoliosis, omphalocele, short cord, and bizarre fetal position, suggesting a limb-body wall complex. We can have isolated bladder extrophy with an abdominal wall defect below the umbilicus with extravasation of the bladder, and cloacal extrophy or OEIS, which would include omphalocele, extrophy of the bladder, and perforanus and spinal defects, including spina bifida. But our patient, our combination of defects would suggest a limb-body wall complex. So this is a condition characterized by multiple severe congenital anomalies, as we've discussed. This includes openings in the anterior body wall, including the chest and abdomen, and or defects in the limbs. These can also include facial clefts, short or missing umbilical cords, scoliosis, neural tube defects, or abnormalities of the urogenital organs, including kidney, bladder, and genitals. The exact cause of limb-body wall complex is unclear, although we do have some leading theories, and there's no cure, and it is considered to be fatal. So the majority end in either fetal demise or stillbirth or death shortly after delivery. The exact cause is unknown, though our leading theories behind the cause of limb-body wall complex include these. First is amniotic bands, which is when the amniotic sac breaks early. We develop these amniotic bands, and these can cause amputations or constrictions in the developing baby. The timing of the creation of the amniotic bands could kind of explain some of the varying severity from case to case. Vascular disruption, which would be a disruption of the blood flow to the developing baby, and this is kind of a common explanation for other or certain birth defects, especially limb abnormalities. And then the last theory is behind abnormal embryonic folding, and if this event doesn't take place, or if the embryo folds abnormally, could lead to the various signs or symptoms associated with limb-body wall complex, but at this point we don't have a perfect explanation. It is rare, affecting between 0.4 and 3 per 100,000 live and stillbirths. The actual rate may be higher due to fetal loss, due to miscarriage or termination. It's not related to parental age or fetal sex, although it may be increased in twin gestations, but within twin gestations can be discordant or concordant. Associated, as I spoke earlier, with urogenital organ malformation, so unilateral renal agenesis, malformations or absence of genitalia or urogenital bladder or both. Anal atresia or severe limb reduction defects, and these would typically be a unilateral lower limb or lower extremity defects. There are varying degrees of severity. Kind of all of these things that I've discussed may or may not be present, but there's the typical combination. So these are defects in the thorax and abdomen with limb defects, where the organs from the thorax or the abdomen may lie outside the cavity and may be contained within the sac. The umbilical cord may be short or absent, and then we can have scoliosis. So it's kind of this combination of the scoliosis, omphalocele, short cord, and then kind of just a bizarre appearance or bizarre lay of the fetal body on ultrasound. You may have, when the umbilical cord is extremely short, you may just have like the fetus appears adherent to the placenta, but that's not the case with our patient. Antenatal testing, a microarray is generally offered to these patients, although this does not generally yield much information. There have been isolated reports of abnormal karyotypes, but it's not the rule. And termination is generally offered to these patients as it is considered lethal in almost all cases. And then as far as obstetric and postnatal management, we recommend vaginal delivery unless maternal indications. Due to the highly lethal nature of this anomaly, we try to avoid subjecting mother to a cesarean section to avoid the higher risk of that procedure. Especially when neonatal resuscitation is not planned. It's important to discuss with your patient the high mortality of this complex and high morbidity if we are successfully able to repair this. This would generally be in less severe cases where it's mostly an omphalocele type of defect, where we'd be able to repair it similar to an omphalocele repair. Prior to delivery, we can also refer to perinatal and neonatal palliative care so that the patients can be plugged in with these resources prior to delivery. Our second patient is a 20-year-old G5P1031.
Take any questions on that case?
Sure. Are there any questions about limb-body wall complex? Sorry, before we move on to the next patient. Not that is perfectly fine. Our next patient is a 20-year-old G5P1031 who presented at 17 weeks and 2 days gestation to the MFM consult or to the MFM service. She was dated by a 7-week ultrasound who presented for routine prenatal care. Her pregnancy was high risk given the following. She has a history of epilepsy. She had a seizure approximately 1 month prior to her pregnancy. And prior to that, she had been on lithium and topiramate. At her initial presentation at 5 weeks gestation, she was not on any medications. At that time, was started on Keppra 500 milligrams BID. She has a history of hypothyroidism, although she's not on any medications. And at presentation, when we obtained thyroid function tests, they were within normal limits. She has a history of a C-section ×1, which was an emergency section for cephalopelvic disproportion with uterine rupture, complicated by a cystotomy and blood transfusion. And about 4 months prior to her pregnancy, she had a recent history of a pregnancy of unknown location versus an ectopic pregnancy that was treated with methotrexate. So this was about 2 months prior to conception, otherwise complicated by Rh negative status. So she was seen by the MFM consultation service at 19 weeks for what was found to be a neural tube defect on ultrasound. As we go through the sagittal spine views, we can begin to see this defect visible in the lower spine. So we'll start up at the cervical spine and the thoracic spine where we can begin to appreciate this defect. And then as we come down to the lumbar spine and down to the sacrum, we begin to see this defect here at the caudalmost aspect of the spine. As we scroll through axial views of the spine, we can see this defect in the vertebrae with some sort of defect at the skin as well, as demonstrated in the right three-most images. And we continue to see this, and we can visualize this on 3D imaging as well, where we note this defect at the lowermost aspect of the spine. And on this image here, we are looking at this defect, and so we see here there are contents within this outpouching of the spine, which would be consistent with a myelomeningocele, whereas just a meningocele would just be the outpouching without the extravasation of the spinal cord contents. In our patient, we also see some evidence, although the lemon sign here is a little subtle, but we do see on the left what we would call a banana sign. So we're looking at the cerebellum here, and it's being flattened as it's kind of being pulled down through this defect as the cerebrospinal fluid is exiting through our inferior defect. It's kind of pulling down. So this would be starting to be consistent with like a Chiari malformation. And then on the right, we see a lemon sign, which is, and I'll show in the next image as well, but where we have kind of this tenting in of the head there, which would be abnormal. So these are kind of more distinct images. So on the left, we see this is the cerebellum. The banana sign is the cerebellum begins to herniate through the foramen magnum. And then on the right, we see the frontal boxing, which would be present in cases of open spina bifida. We'll have a brief discussion of neural tube defects. So these are relatively common congenital anomalies developed when a portion of the neural tube fails to close normally during the 3rd and 4th weeks of development. These can involve the vertebrae, spinal cord, cranium, and/or brain. They can be open or closed. The vast majority are open, and the majority of those are what we would call a myelomeningocele, which would be our spina bifida. So this defect is covered by a membrane or may be covered by nothing at all. And this would include a range of defects, including a meningocele, myelomeningocele, encephalocele, or anencephaly. Closed defects are more rare, but this would be a defect that's still covered by skin, so a defect in the vertebral column, but still covered by skin. These can have a tuft of hair, birthmark, or dimple, and this would include like a lipomyelomeningocele or a lipomeningocele. There's substantial morbidity and mortality associated with neural tube defects. These can have varying degrees of neurologic development depending on where the lesion is, and these can impair cognitive function, and a lot of that is dependent on the presence of ventriculomegaly and the effect on the actual cortex of the brain during development. The embryology of neural tube defects, we won't go too deep into this, but during the 3rd and 4th weeks of development, when we have the folding of the ectoderm and we begin to have the neural groove, the neural folds, and the neural crest cells that form to make the neural tube and leaving the surface ectoderm. This begins at the cervical portion and extends caudally and cranially, which is why we tend to see these neural tube defects at the inferior and superior most portions of the spine. These can range, again, depending on where the lesion is, from anencephaly down to open or closed spina bifida at the inferior most portion. And again, just to reiterate, the meningocele versus the myelomeningocele depends on the contents that's extruding through the defect. Meningocele on the left and myelomeningocele on the right. There is some variation in what our understanding of the cause of neural tube defects, although it is generally accepted that there's at least a majority of blame to be caused by folate deficiency. Most isolated neural tube defects are related to folate deficiency, likely in combination with some sort of combination of genetic or environmental factors. This can be decreased intake, adequate absorption, genetic factors, or use of folate antagonists, which would include valproic acid, carbamazepine, or methotrexate in our case. Folic acid supplementation has been shown over the years to markedly reduce the incidence of neural tube defects. And if we look at women with a child with a neural tube defect or a history of pregnancy complicated by neural tube defects, we find that their serum and red cell folate concentrations are lower. And with mothers who have a history of progeny with neural tube defects, they have been found to have a higher incidence of MTHFR mutations, specifically homozygous mutations, although having those mutations do not necessarily predispose you to having progeny with neural tube defects. There are no other specific genes that are identified, although there does seem to be a strong evidence for a genetic component, as these defects are highly concordant, more concordant with monozygotic versus dizygotic twins. They tend to occur in families and do tend to happen in female fetuses more than males. It is relatively common, with the US rate of 0.2 per 1,000 live births, most common in the US and Hispanic populations. There are areas in the world where it's up to 7 per 1,000 live births, in those areas with the highest rates. Girls tend to be affected more than boys, and the recurrence rate, if you have a previous birth with a neural tube defect or a previous gestation with neural tube defect, recurrence rate is about 2 to 3%, which is about 20 times the average in the general population. These prevalence rates quoted reflect kind of genetic and environmental differences, which would include supplementation in the food supply and access to care, but also access to termination, as these rates are prevalence rates per live births. Neural tube defects can be associated with a host of syndromes and trisomies and triploidies, and other malformations, including, as we noted in our first patient, a limb body wall complex, collateral exstrophy, or OEIS. For prenatal prevention of neural tube defects, women at low risk without a history of neural tube defects and without family history of neural tube defects should be on 0.4 milligrams of folic acid supplementation at least 1 month prior to conception through at least 12 weeks of gestation. And the reason that we begin all women on supplementation is that 90 to 95% of cases occur in women without any risk factors. Those at high risk, which would include prior pregnancy or family history, should be on 10 times that amount with 4 milligrams of folic acid daily. We offer screening to all pregnant women, and there are 2 main ways of screening for neural tube defects. First is by ultrasound, using late first trimester studies, so in the 12th to 14th week. We can detect major anomalies, including anencephaly and encephalocele, although it's more difficult to visualize minor defects or lower defects like a myelomeningocele. So if you have a normal late first trimester study, that should still be followed up with a second trimester study around 18 to 20 weeks, where we can detect up to 95% of myelomeningoceles and up to 100% of anencephaly. Our other screening would be serum biomarkers, so alpha-fetoprotein. This can be done between 15 and 20 weeks, although 16 to 18 is ideal. This is influenced by many factors: gestational age, maternal weight, multiple gestations, etc. And so the results are given in multiples of the median. And these have the benefit of detecting other abnormalities, including abdominal wall defects, although by ultrasound we should be able to visualize those as well. Depending on the lab, the value that we would use would be greater than 2 or 2.5, depending on what our cutoff is for our false positive. If we use 2.5, which is kind of the standard, that would include like a 65 to 80% detection rate with a false positive rate of about 1 to 3%. As far as our antenatal management of a patient who presents with a neural tube defect, it can be nuanced, and we need to guide these patients through the decision to prepare for a birth of an affected child or the decision for termination. They should be evaluated for other syndromes or other chromosomal abnormalities. They should have a complete anatomic ultrasound. They can have a microarray, which would be our genetic test of choice to detect smaller subset chromosomal copy number variants. and consider a fetal MRI if our ultrasound results are inadequate or inconclusive, but we still see some defect. There are many support groups and parent groups available for parents who have had an affected child, so they can connect with those groups, even to help them with the decision to prepare for birth versus termination. And we can consider referral to a spina bifida clinic to discuss further the prognosis, postnatal management, and treatments available. Fetal surgery is an option for some of these patients. We can consider this for like a myelomeningocele without other major structural abnormalities and a normal genetic test. The goal of this is to arrest or stop the leakage of this cerebrospinal fluid from the defect to prevent high-brain herniation or like a Chiari-2 malformation hydrocephalus. There are several centers throughout North America and Europe, although this comes at a high risk and high cost. So the risks of doing some type of fetal surgery would include preterm birth, intraamniotic infection, chorion-amnion separation, PPROM, oligohydramnios, abruption, pulmonary edema, maternal bleeding, maternal transfusion, and uterine thinning and dehiscence and uterine rupture, depending whether they're doing this open or fetoscopically. This is a quick video kind of showing what a fetoscopic surgery of repair of a neural tube defect. I don't know. Otherwise, during the pregnancy, we should monitor this pregnancy with serial growth ultrasound, monitoring for head size, presence of associated Chiari malformation, ventricular size, and neural tube defect size. We can mostly deliver these patients vaginally, as long as baby is cephalic. We should use latex-free gloves, as myelomeningocele patients can develop life-threatening latex allergy later on in life. However, cesarean delivery may be indicated for any maternal condition if the fetus begins to have macrocephaly with the BPD greater than 99 percentile or greater than 12 centimeters, depending on timing of delivery. If the fetus is in breech position with a myelomeningocele, we recommend cesarean delivery, or if there was a fetal repair and a hysterotomy was performed at that time. We want these babies to deliver as close to term as possible to prevent complications of prematurity in combination with neural tube defect, and these should be done at a location with at least a level 3 NICU with pediatric neurosurgery availability. Postnatally, management of the mother doesn't change, but of the fetus, management depends on the severity of the lesion, so they should be available for postnatal evaluation at a location with neurosurgery. And then it depends on the absence or presence of Chiari-2 malformation or hydrocephalus and the level of the lesion. Although because many of these lesions are lower, bladder and bowel are affected in the vast majority of these patients. Any questions? on regarding neural tube defects or regarding our patient?
Yes, can you hear me?
Let me see really quick if I can figure out our sound. Give me
I can
one
hear
moment,
him a little bit.
'cause we
Can you hear me? I can talk louder. Can you hear me okay?
Try one more time, Dr. Lehman.
Yeah, can you hear me now?
It's quiet in the room, but I can hear you.
You can hear me, okay. So one thing I would just look at, check OMIM, because there are 5 genes now that are associated with neural tube defects, and several of them, I mean, they've found likely pathogenic variants, and some of them they've shown in vitro. So, and they look autosomal dominant. So I would just check that out, because there is some evidence for genetics now.
Okay. Yeah, and I believe that those, so did you hear that?
I did not.
So he said that in OMIM, there are some genes that are associated with neural tube defects. What is your typical practice with these patients? You do genetic testing?
Yeah, diagnostic testing, amniocentesis with, microarray.
Yeah, so we would typically do a diagnostic test, like an amniocentesis with a microarray for these patients to rule out any other genetic abnormality.
Right, that would not pick up point mutations in single genes, though. And I'm not saying that should be done, but there are 5 genes, just to be aware. I'm sure there are going to be more in the future, and genetic testing is probably going to be possible for that.
Yeah, so there was some discussion about whole like exome sequencing or other genetic testing where we would be trying to pick up point mutations. I just think that we're not quite there yet.
I mean, we certainly can do that. In this patient, remember, she had methotrexate exposure, and she also had dermic exposure early in the pregnancy. So both of those, are potential teratogens and certainly are associated with an increased risk for ONTDs. So we weren't really traveling down that route, and the patient was not interested anyway. We didn't have any genetic diagnostic testing in this case, but yeah, good point.
So I'm not sure if everyone could everyone hear Dr. Montero?
Yes.
Okay. And our third patient is a 40-year-old G8P5025 who presented at 8 weeks gestation to present to establish care. She has a history of chronic hypertension and cesarean delivery ×3 and a personal history of umbilical hernia. She was previously on diltiazem, HCTZ, and triampherine to control her blood pressure, but had stopped those prior to pregnancy and is now placed on nifedipine as she had some elevated blood pressures. NIPS was performed at 12 weeks, screening for a trisomy and sex aneuploidy, which was all normal or low risk. Her first trimester ultrasound was normal. However, at her 20-week detailed anatomy ultrasound or screening anatomy ultrasound, there was noted to be a 1.5 by 2 centimeter echogenic mass in the left thorax. So the differential at that time included congenital pulmonary airway malformation versus bronchopulmonary sequestration versus posterior left diaphragmatic hernia with liver protrusion, although it was difficult to differentiate those at that time. So here's that ultrasound. So we note an echogenic mass in the left chest on axial and coronal views. And then these are some videos scrolling through. Both of those views as well. The lack of blood flow noted to the mass from systemic circulation favors our diagnosis of congenital pulmonary airway malformation. So this is kind of the sequence of events from that time. So at the 20-week anatomy ultrasound, we noted this echogenic mass in the left thorax. On fetal echo at 24 weeks, there was noted mesocardia, so displacement of the heart towards the center of the chest, but otherwise structurally normal. We performed a follow-up ultrasound at 27 weeks, which showed a persistent 1.5 by 2.2 echogenic mass in the left thorax. There was still no blood flow to the mass, so more likely a CPAM. And then we also calculated a CPAM volume ratio, which I'll discuss in a little bit, showing low risk for a hydropic fetus or risk of hydropic fetus and no fetal hydrops at this time. So she's scheduled at this point for further MFM consultation and pediatric surgery consultation. And at the 20-week gestation, I just wanted to show this again. So this is the measurement of the mass at that time. So we're going to discuss briefly congenital pulmonary airway malformation. This is a developmental malformation of the lower respiratory tract and a congenital cystic lung lesion. These are abnormalities of the branching morphogenesis of the lung. These are sporadic malformations not related to maternal factors such as age, race, or exposures, and they may or may not be more common in male fetuses. It's divided into 5 subtypes based on the distinct pathologic characteristics. So we do not always have the pathology of these fetuses because if they are born alive and survive, we don't always get that pathology report. But we can differentiate kind of based on some of the findings. The different types may originate at different levels of the tracheobronchial tree and at different stages of lung development. CPAM was previously known as CCAM, or congenital cystic adenomatoid malformations, and they were originally divided by the origin of the tissue. So I'll briefly go through these since this is not something that we all need to memorize as this is fairly rare. So type 0 is the rarest form, only about 1% of the cases. This originates from the tracheal or the bronchial tissue. The cysts are small. This is a diffuse malformation, covers the entire lungs. Gas exchange is severely impaired, and virtually all infants die. Type 1 is most common. This is about 60 to 70% of the cases. This is thought to originate from the distal bronchi or the proximal bronchioles. These are comprised of distinct thin wall cysts that are 2 to 10 centimeters in diameter. They're usually single cysts, but they can be multiloculated. The adjacent lung tissue is relatively normal, and in most of the cases, only one lobe of the lung is involved. And the clinical presentation of the infant at birth depends on the size. It can cause respiratory distress, mediastinal shift, or if small, can just present as like a nidus for infection or as an incidental finding later on in life. Type 2 comprises about 1/5 of the CPAMs. These are multiple smaller cysts, less than 2 centimeters in diameter, with solid areas that blend into the adjacent normal tissue. There's usually little mass effect on the adjacent lung because it kind of blends in. These can be confused with other malformations, including extralobar pulmonary sequestrations, but these, as noted in our patient on our imaging, CPAMs do not have connection to the systemic blood supply. Other congenital anomalies can be observed with these patients with type 2 CPAM, including esophageal atresia, tracheoesophageal fistula, renal agenesis or dysgenesis, or other like diaphragmatic, cardiac, or CNS or bone abnormalities. Type 3 is about 5 to 10%. These come from the acini, so that from acinar origin, can be a mixture of cystic and solid tissue, or it can be entirely solid. These are the most severe form besides type 0, which is completely lethal. These are large lesions. They can involve the entire lung. These can include or these can cause secondary fetal hydrops or pulmonary hypoplasia, and these infants can be stillborn or present with severe respiratory distress or respiratory failure. And type 4, which is again about 5 to 10%, these cysts have a maximum diameter of 7 centimeters, and these are non-ciliated flattened alveolar lining cells with no mucus. These often present with a pneumothorax or infection, and these are strongly associated with malignancy, mostly pleuropulmonary blastoma. So, in general, CPAMs are rare, but they are the most common congenital lung lesion. Large lesions occur in about 2 to 8 per 100,000 births. Typically, they're an incidental finding found on screening ultrasound, and up to 50% of these cystic lung lesions found on ultrasound can regress or appear to resolve by birth on ultrasound, but on imaging after birth can still often be detected. They peak in size at about 25 weeks gestation. And on imaging, we classify these as either microcystic or macrocystic lesions, depending on the size of the cyst. And we evaluate using the CPAM volume ratio, which gives us a reference for our risk of hydrops and is used as a prognostic indicator. So this is the CPAM volume referenced to the fetal head volume, and we can also use MRI to distinguish from other pulmonary anomalies, and we use follow-up ultrasounds depending on the severity of the lesion every 1 to 4 weeks to follow up. This can be associated with other anomalies, mostly with type 2 CPAMs, and we should obtain at least a fetal karyotype. For genetically, the rate of aneuploidy is not increased in association with CPAMs. However, if they have severe forms, like if the patient or if the fetus is hydropic, they may have an increased risk of genetic abnormalities, so we should perform at least a microarray for a hydropic fetus if we're planning on any sort of intervention. Fetal hydrops can develop in a minority of these cases, between 5 and 40%. This is due to the hemodynamic alterations due to obstruction of the vena cava or displacement and compression of the heart. We use this CVR, the ratio, to predict the increased risk of hydrops. Our patient's CVR was 0.15. The cutoff for high risk of hydrops is 0.16. So we were just below that cutoff.
1.6.
Oh, 1.6? I thought it was 0.16. Oh, 1.6.
Yes.
So we are far below, sorry. A little dyslexia this morning. If we find fetal hydrops at greater than 32 weeks, we can proceed to delivery to prevent further complications. And if less than 32 weeks, if hydropic, we may require some early intervention. The interventions that we have available, first and foremost, is medical. We can use betamethasone. We use standard dosing. This is the only medical therapy for hydrops and those at risk of preterm delivery. A single course can actually reverse the hydrops that we see in these patients, but those that don't respond to one course may benefit from multiple courses, typically spaced out about 2 weeks apart. There are more invasive procedures, which would all still be considered investigational, and the more drastic fetal surgery intervention, including resection and laser therapy, have only been used in a small number of patients. So this kind of depends on the nature of the lesion, whether it's micro versus macrocystic, and whether it's dominant cysts versus a solid mass. If it's cystic, that's a little simpler. We can do a thoracentesis or a cyst aspiration or place a thoracoabdominal shunt during the pregnancy, although that's not a simple procedure. And surgical resection can be performed during the 20 weeks gestation between 21 and 29. We can do laser ablation of these solid masses, or sclerotherapy seems promising, where we inject an ethanolamine into the mass fetoscopically. And this can help reverse fetal hydrops. But again, these procedures are only done in the most severe of cases and after we determine that there's no other malformations or other genetic or syndromic things going on with the fetus. For delivery, if the malformation is small, there's no need for early delivery or cesarean section. We should coordinate with the pediatric staff, including NICU and pediatric surgery. If large or complicated by hydrops, we need to make sure to perform these at a tertiary care center where immediate access to pediatric surgery, because those with large lesions or significant difficulty with respiration or respiratory failure may require immediate resection after birth. For some of these patients that we expect to have difficulties with respiration after birth, we can do what's called an exit procedure, which is used to improve the outcomes of these hydropic fetuses. Where during the cesarean delivery, we partially deliver the infant, we keep the uterus relaxed, and we intubate the fetus or the infant prior to full delivery and prior to cutting the umbilical cord. Any questions regarding CPAM? All right, well, thank you so much for joining today. If there's no further questions, I just want to thank Dr. Montero for the images and the consultation regarding these cases, and maybe Dr.